Good afternoon. Welcome to today's CAPE CPD webinar. My name's Sam Campbell. I'm the Research Director for the ED in Halifax, Nova Scotia. I'm originally from South Africa. I know very many of you guys. I trained in Vancouver and I was chief of the Charles V. Keating Emerge in Halifax for about 10 years. And it's my great pleasure to moderate this webinar today. The webinar topic was independently conceived by the Scientific Planning Committee, led by Eddie Lang, and including Stacey Kitts, Kira Grewal, and Peter Iroklasius. None of whom have any conflicts of interest to declare. My disclosures are as follows, and I don't think I have any conflicts regarding the topic at hand. The presentation was made possible by an educational grant from GSK and Pfizer, and we'd like to thank them both for their generosity. All efforts were made to mitigate any potential biases. Just a bit of background on this topic. The webinar is the second of a two-part series. I hope most of you caught the first webinar a couple of weeks ago, which was about predicting in the current predictions of the current state of COVID in the ED for this winter. It is available on replay if you missed it. Today's webinar covers COVID treatment. These are the learning objectives of today. I'm not going to read them. I'll let you read them. The first two were covered on the previous webinar, and we're going to complete the last two today. So they're specific learning objectives specifically to COVID treatment. And I'll let you read those. So we have two fantastic presenters today, and it's going to be a kind of tag team where we'll be jumping from one to the other and back again. We do want it to be interactive, and we're also trying to squish an enormous amount of information into an hour. But we do encourage you to use the chat feature. If everyone looks at the top right-hand corner of their live stream, there's a little cartoon balloon there. If you click on that, that'll open your chat option. So please enter your questions. We'll try and address as many of those as we can. We're going to have a Q&A section at the end of the presentation and maybe doing some audience polling during the webinar using the chat function. So I'm just going to introduce our two speakers. The first speaker is going to be Zane Shagler. If you were in last week, he spoke. So welcome back, Zane. During this COVID crisis, Zane has contributed to local, provincial, and federal policy plannings and to several clinical trials on COVID-19 therapies. He's an associate prof at McMaster, co-medical director of infection control at St. Joe's in Hamilton. He's a consultant in infectious control at Woodstock General. He has a BSc and an MD from Queen's. He did a residency in internal medicine in Western and an ID fellowship at McMaster. He also has an MSc in ID and a diploma in tropical medicine from the London School of Hygiene and Tropical Medicine. The next person in the tag team is Lenora Saxinger. Lenora is an infectious disease specialist whose pre-COVID work focused on antimicrobial stewardship and resistance, with evolving work in evidence synthesis, knowledge translation, and science communication. She was co-chair of the Alberta Health Services COVID-19 Scientific Advisory Group from 2020 to 2023. She's a professor in the Faculty of Medicine and Dentistry, the medical lead of antimicrobial stewardship for Northern Alberta and Alberta Health Services. So thank you both very much for coming and spending time with us today. Zane, I'm going to let you start with the presentation on recognizing the severity and appropriate risk stratification of COVID-19 patients in the emergency department.
Thanks, and thanks for the introduction. Happy to be back. So today, I think, it was a continuation of a couple of weeks ago where we're going to go through, again, a little bit more of that risk stratification, talk about early and late treatment, and then kind of short-term consequences of COVID and long-term consequences of COVID that need to be recognized by the emergency physician, and then again, time for questions. So this section is really around, again, staging, and I think we talked about staging a little bit at the last point, but really kind of, that decision making of who is at high risk and who needs more monitoring in that context. So recognizing severity and stratifying appropriately. These are my disclosures, and including a number of studies. And so, again, as we talk about the natural history of COVID-19, we have the initial infection where people can be asymptomatic or symptomatic and have recovery at that point. When they're symptomatic, they go through this early viral phase where they're kind of feeling flu-like, myalgias, now, the typical symptoms, where again, they may have recovery, a small percentage have recovery and then subsequent rebound. And we'll talk a little bit about rebound a bit later. And then, again, those who don't recover then kind of get into this inflammatory phase where much of the virus is cleared out of their system, but aberrant inflammation leads to respiratory complications and other systemic complications where they may recover with a little bit of anti-inflammatory therapy, or they may get critical illness requiring ventilatory support and again, require escalating therapy, some recovery, and again, and death or sequelae. And then with all of this, especially in symptomatic COVID, we have kind of post-acute COVID, and some of that is, short-term consequences that occur in the few weeks after COVID, and some of that is some of the long-term consequences that we see of COVID, and again, do correlate to severity of disease in terms of the risk of these post-acute phenomenon. And so, just to, as you're staging that person, I always bring up this graph, that age is probably the biggest predictor of staging than anything else. And so this is data from the last, I believe, 120 days in Ontario when last published in terms of breakthrough cases requiring hospitalization. Vaccine status is obviously the one stratifying factor so that, people who are not vaccinated face a higher risk of hospitalization than other populations. But, of the breakthrough infections, if you were to pick one thing out of a hat that would determine the risk of hospitalization or people's moderate to severe presentations, is age, and really age over 80 where the highest risk occurs, age over 60 where we see more of the age-related risk occur. And then, again, a younger person, the likelihood is lower, although, still a number, especially in the unvaccinated population. But, again, in doing that staging of that person that shows up with COVID to the emergency room that you're making a decision on admission, age may be one of those first things that comes off the top to say, is this someone that's high risk or low risk? This is a data from a breakthrough database in the United Kingdom of about 330 million individuals, and really just tracking other risk factors. So again, on the left, we see age as a risk factor for breakthrough infections leading to hospitalization. And again, really starting to see the trend at 60 and then, starting to break through at 70 and really a profound difference at 80 and above. In terms of immunocompromised or conditions that lead to higher risk, I think we talk about a litany of different conditions, but the ones that really do cluster at the top are, organ transplant, renal transplant, bone marrow transplant, immunosuppression, where, not only do they face a risk from, poor vaccine responses, but poor viral clearance and everything else that takes them into the transplant. We see, neurologic disease, chronic kidney disease, blood and bone marrow cancer, cirrhosis, and again, higher level chronic kidney disease kind of being overrepresented at the top. And the other part of this is, even though people are presenting with symptoms, things like diabetes type 2, even though we think it's a higher risk condition, it certainly is a higher risk condition, but it clusters towards the bottom of increasing risk. Same with the asthma, clusters towards the bottom of increasing risk. And so, again, as you're getting that assessment of the person, more advanced end organ disease, immunosuppression are the two medical conditions that tend to cluster at the highest risk end. And then, at the lower risk end, we talk about things like stable end organ disease, stable diabetes, asthma, where there is an increased risk, but it's not necessarily as profound as some of those higher risk conditions. This is some data and just kind of practically of the outcomes of people presenting to the emergency room with COVID-19. This is French data from a large cohort looking at people presenting to hospital with COVID-19 and their outcomes at the end of the day. And I think we also do see, as the variants emerged and the severity of the variants emerged, as well as immunity that derived within the population, the outcomes are very different in terms of patients that were, showing up to the emergency room with Delta versus the emergency room with Omicron, right? So, in the top chart in table 2, we see that discharge home of patients with Omicron versus Delta, so a 58% rate of discharge versus a 36% rate of discharge with Delta, a 38% admission rate to the ward with Omicron versus a nearly 50% admission rate with Delta. That even direct admission to the ICU was much lower, 3% versus 14%, and secondary admission for other reasons, again, lower. And mechanical ventilation much shorter, hospital stays shorter, and median ICU stays shorter. And so, I think you get a sense here in the context that the average person who presents with Omicron may be dischargeable in the context of everything, again, barring it, symptoms or vital signs or other abnormalities that would require hospital admission. And I think you can see in the evidence here that in other centers that many of those patients can recover at home adequately. Even those patients that are admitted to hospital with COVID-19 in this cohort, and so there was 244 that they looked at versus 456 in the Delta cohort, and they saw, again, that the vast majority of them recover on the ward, that only 9% the Omicron cohort versus a quarter of the Delta cohort required an intensive care stay. Very few required mechanical ventilation, and again, their mean hospital stay and ventilatory days were much lower, and the death rate was much lower in the Omicron era versus the Delta era. And so, again, this is probably more reassuring that those people presenting to hospital, likely could be discharged home, but B, even if they do need a hospital admission, should be short and again, working towards particular things, like just dealing with the hypoxia with dexamethasone or fluid resuscitation or that type of thing. But that decision making to discharge home could be supported by the fact that, again, most of the emergency patients can be discharged home, and in larger cohorts have been discharged home in that sense. And so the question comes, who to admit to that person that shows up to the emergency room. Number one is, I think it's pretty similar to other respiratory viruses. So not necessarily based on that patient, in terms of, their medical history and risks, especially with the context of early treatment that Lenora will talk about. But, again, the other respiratory diseases that present to the emergency room, hypoxia, organ failure, cognitive issues, volume depletion, frailty, social and discharge situations. And that may be the one thing that's a little bit different in the context of people going into areas where there is a high outbreak potential without having the resources in place to actually isolate appropriately. But many of these decisions are similar to anyone presenting with acute respiratory symptoms to the emergency room, not necessarily banking on the risk, although you can use things like age and immunosuppression to kind of get a sense of risk. But again, the reason for admission should really be around the same things that lead to other people being admitted to hospital for viral infections. There isn't anything specific to COVID that I think would change things, and at least, again, reassuring data that many people can be discharged home appropriately. And I reemphasize this. This is a real-world study of nirmatrelvir/ritonavir. This is not to talk about therapeutics, but this is real-world data from the United States from a large healthcare network. And we do see nirmatrelvir/ritonavir in the study works, which is the primary finding, which is great. But I will say, the risk of hospitalization within 14 days in this high-risk cohort that we see in the left is less than 1%, even in the context of non-treatment with appropriate antivirals, and death within 20 days is quite low. And so, I think that there is some reassurance there that even in these high-risk cohorts, as long as they're being managed adequately, if they're eligible for treatment, that they, acquire treatment and take it, you're talking about a hospitalization risk that is well less than 1% in that cohort. And so, yes, you want to focus on the highest risk people, the elderly, the immunosuppressed, but the reality of the situation is in a large high risk cohort, you're still capturing only a 1% risk of hospitalization, which is very different than prior therapeutic clinical trials where it was 5% or higher in that sense. So, the disease has changed in the context of immunization and other factors. And so, again, that ability to discharge people home and recognize they do okay is probably reasonable in that context. Okay, with that, I will flip over to Dr. Saxinger here to talk about therapeutics.
Thank you very much. Next slide, please. So I actually try to avoid any potential conflicts of interest because I'm on a formulary committee. So any potential conflicts are mostly related to grants or other unrestricted educational events. Next slide. So I have a couple of bottom line issues that I want to bring up right off the bat, and then the rest is kind of same old, same old. And I think that we're looking at the same drugs that we've been using and just kind of reinforcing the best place to use them. So all of the antivirals, and I expect any new ones, will also likely work best if you start them early. So within the first 3 days is great, within the first 5 days is pretty decent, within the first 7 days is still useful. And people therefore still need to test early with symptoms. And so I think that that's kind of fallen off the radar a bit for some patient groups. And so high-risk patient groups especially, they should, be reminded that you have to test. And if the treatment criteria in the province you're in includes the need for a PCR test, they can do a RAT at home, but they should also get a PCR if they might be eligible for therapy. And the other thing that has been discussed already is that, we now have highly vaccinated and highly, immunologically experienced populations. And there's very limited, RCT type data on effectiveness of the therapies in those groups. And there's increasing amounts of observational data of variable quality, which gives us some insight into that. But, Zane just said the severe outcomes have become very rare overall compared to the volume of infections. And so really we're trying to figure out, like the needle in the haystack, who is the group to target for therapy? And we're also going to talk about outcomes beyond severe outcomes, like hospitalization. All the monoclonals are now, they're kind of time-limited drugs because if the virus changes too much, you're not going to have good antibody binding anymore. And so these drugs can become obsolete quite quickly when you have a shifting virus. And that's what we're seeing right now because of decreased neutralization activity against the current circulating variants. I wouldn't throw them out because you never know what might happen next if there's some left and it's still viable, but they're not really a relevant treatment option anymore. Just reminding everybody that hypoxic patients should get dexamethasone and non-hypoxic should not. And progressing hypoxic patients should get tocilizumab or baricitinib. And I expect that sometimes, given today's medical situation, sometimes these patients actually are in the emergency room for longer than we might expect. So those become relevant. Next slide, please. I put up this slide. It's a bit of a confusogram, but it shows the variation in the provincial and other jurisdictions' eligibility criteria for Paxlovid. And so the number of vaccine doses, some of the guidelines are the same regardless of the number of vaccine doses, which is on the left. The number of comorbidities is on the right, and the age is across the bottom. And so the ones with the most color are the ones that have the most open criteria. And, this just basically shows that it's all over the map. And that reflects to some extent the type of evidence that we're dealing with and how it's being interpreted. We recently updated our criteria. So this is our old criteria. But, right now, 94 to 99% of the population is seropositive due to vaccination, infection, or both. And so there's a lot of immunologic experience built up. Next slide, please. So just to go back to the registration trials on Paxlovid, the EPIC-HR high-risk study showed like a really awesome reduction of risk of severe outcomes of 88%. Now that's no longer the case for a variety of reasons. And in that group, which was a high-risk cohort, 6.3% was the hospitalization rate in the untreated versus 0.77% in the treated group. And that was actually very, very solid results. And in the seropositive group, though, so this is kind of like how you might start looking at our vaccinated and seropositive groups. it was actually 1.5% versus 0.2%. And that's kind of more towards the end of what we're seeing in most studies now. So the number needed to treat to avert hospitalization, which is the dominant outcome in all of these studies, has gone up a lot. I will comment that the price has not gone down a lot. And so therein lies a lot of the current discussion and the discrepancies. There was another study from EPIC, the standard risk group. This has still only been released in press release from June 2022, unless something changed in the last week. In that group, it was 1.8 versus 0.9% hospitalized. So still a benefit to the individual, but lower risk across the board. And in the vaccinated high risk group, it was 1.9 versus 0.8%. So basically the same. The number needed to treat, depending on what data set you're looking at, can be as high as 200. And so the cost to prevent one hospitalized patient can be quite considerable. Next slide, please. And I should actually comment on one other study that I don't have a slide on, which is Kevin Schwartz's study from Ontario, which is, I think, out, but not really out, because I think it's dated February 23rd. And it's another observational study that probably does a better job than a lot of studies in controlling for some of the issues of observational studies. And it was has slightly different baseline hospitalization rates, which are more in the realm of 2 to 4%. And that's probably because they used a PCR test positive group. And right now, most provinces have restricted PCR testing. So if you got a PCR test, you're probably already selecting out a higher risk group. And in that study, there was still benefit seen to Paxlovid therapy. And it was actually around a third reduction of severe outcomes towards the latter part of their study, which was in the summer. And the number needed to treat varied a lot, but it was pretty solid in those who are over 70 and those who have less than two vaccines, which kind of behave very similarly. So, you know, it's more than hospitalization though, and most of these studies are looking at hospitalization. So people are interested in, you know, the time to recovery, which can have a significant impact on people's function. I will say that EPIC HR collected that data, but it was never shared, and that EPIC SR showed no significant difference. It was about 13 days time to recovery in each arm. The data on transmission reduction is also lacking presently, but people are starting to look more at these outcomes. It's intuitively attractive to imagine that if you have someone with an active viral infection that could be spewing virus all over the place and you give them an antiviral drug, that you might actually have a lower viral load more quickly and reduce transmission. It's interesting though, the post-exposure prophylaxis hasn't worked, and the viral load decrease seen in the other studies was only modest in the studies where that was followed. So because most of the transmission happens like the day before and the first few days after infection, before people actually get on antivirals, it's not clear that that's going to be a big feature for antiviral use. And then the final big one, which ties into the later part of our study, of our talk today, is actually data on the incidence of long COVID. This is a really significant concern, and people are very interested in it. And I'm just going to say up front, and we're going to talk about it in more detail later, that there's no really great data on this outcome. I expect we will get more. Next slide, please. So the long COVID reduction, the VA study that I just mentioned, they actually compared 9,200 treated and 4,700 untreated patients that were mostly, you know, white males because it's Veteran Affairs with at least one risk factor. They were all tested as outpatients. They weren't able to account for care elsewhere, and they weren't able to account for, you know, patients who subsequently went into hospital. And the outcomes they looked at weren't really exactly what most of us think of as long COVID, because they looked at thrombotic complications, heart disease, renal disease, shortness of breath, neurocognitive change. And it was a diagnostic database search. And there was an absolute risk reduction of 2.3% in those diagnoses being, you know, occurring after COVID diagnosis. And so there's a lot of issues with that study. And I'm just going to say that you see a lot of headlines saying Paxlovid reduces the risk of long COVID, but you can't really say that from this type of study. This is a hypothesis generating study, and it shows an association with reduced outcomes that are specific clinical diagnoses. Next slide, please. Now, there are trends lately to lower barriers to using Paxlovid. So because, you know, it's available, because there's stocks on hand, because, you know, we're worried about people who are high risk not being able to access it. Most provinces have been actually changing their criteria to make it more accessible, but the benefit remains unclear in terms of, how much benefit you get if you're under 70, under 60, under 65. It actually does have some side effects. Dysgeusia is common, and medication interactions are always a concern that require, some time and thoughtful management and adjustment. And we still have a problem where patients in areas of high social vulnerability are not able to access treatment as well. So we haven't really got to the equity issue there yet. So who should get it now? Across all the provincial guidelines, the focus should be at those at higher risk for severe outcomes, and the dominant one is hospitalization. So older age, multiple comorbidities, under-vaccinated, or risk for poor vaccine response. Commenting that a lot of people who think they're immunocompromised, the data doesn't support that the immunocompromise is that severe. And then, of course, we have alternate antivirals that we could use if drug interactions prohibit use of Paxlovid, like remdesivir. Next slide, please. So I kind of, in my head, think of remdesivir as being our in-hospital antiviral, or for high-risk patients with drug interactions that prohibit Paxlovid use. So the two cases that it's mostly used are for people with moderate COVID within 7 days. It's 5 days usually of IV therapy. And there, with that, was a small survival benefit in the final analysis of the Solidarity trial, and less need for mechanical ventilation. That was a little more dramatic as a secondary endpoint of the CATCO trial in the Canadian cohort. And that latter part, the less need for mechanical ventilation for the hospitalized patients, I think is a point that is useful. And then also we have early treatment of high-risk outpatients, and that's usually a 3-day course. We see that used a lot, for example, with transplant patients who have Paxlovid drug interactions. And the 5.4% versus 0.7% hospital admission is quite impressive. And most provinces have referral pathways for outpatient IV therapy for patients who, are eligible for treatment but can't receive Paxlovid. Next slide, please. Immunomodulatory therapies in severe COVID. We see some guideline variants across places too, but I think that there's some things that are true across all the guidelines, which is hypoxic, get dexamethasone. If someone's hospitalized on oxygen, they usually get remdesivir and dexamethasone. Some provinces recommend that if patients are progressing with cytokine storm, that you would give them baricitinib, which is an oral course of 2 weeks. And for critical illness, the data doesn't really support the antivirals so much, but it does report coming out swinging on the immune side with dexamethasone and tocilizumab and or baricitinib. And there's a little bit of variation in guidelines there. Next slide, please. So what happened to drugs like Evusheld and even before that, sotrovimab? Monoclonals were, a very useful intervention for much of the pandemic. But looking at what's been going on in terms of the circulating variants, there's a couple of subvariants from both the BA.5 group and BA.2 group, which are dominant. And all the circulating dominant strains now have significant reduced neutralization by these antibodies. And so those are kind of on the shelf again. Next slide, please. I'm going to hand it back.
Mute. Okay, so tying to this, I think is kind of okay. You made a treatment decision, and really what to do with that patient that presents kind of in treatment, after treatment, that has symptoms after their COVID-19, and kind of recognizing short and long-term complications. So I'm just going to go on a case here. So this is a 75-year-old female. She's had COVID that was documented 2 weeks ago. Her history includes COPD, coronary artery disease, and atrial fibrillation. She's on Spiriva and Advair, rivaroxaban, diltiazem, and rosuvastatin. She had 2 vaccines at the time of her COVID infection. She's recovered. She got nirmatrelvir ritonavir. But based on the drug-drug interactions, someone had to pause her rivaroxaban and diltiazem for a week in order to get it, because they would become toxic with the interaction. And she feels like she recovered, and 2 days later presents with increasing shortness of breath, chest pressure, and malaise. And on examination, she's tachycardic with an irregular pulse at 110, 120, blood pressure 110 on 60, which is pretty close to her baseline. Her temperature is 37.7, her rest rate is 20, her sats are 94% on room air. You try to walk her around the department and it's about 90 to 92%. So, this is that patient after COVID. And there is a pretty broad differential diagnosis here. You can talk about COVID-related factors. Maybe this is a rebound. We'll talk about rebound. You had to make some medication changes for her. So maybe the reduction in medications, particularly diltiazem and the atrial fibrillation, might be causing issues. We talked about COVID-induced cardiomyopathy or myocarditis, which could be an issue now, especially with her hypoxia and congestive heart failure. With the fevers and hypoxia, a secondary infection like bacterial pneumonia on top. And so a number of different things that can come up in that patient that really do have to be walked through, not only just blaming it on the COVID, but, again, the consequences of going on Paxlovid or other parts in that sense. So, to me, going through this case, I think we have a few things on differential diagnosis. So COVID-related things, which I'll talk a little bit about, rebound infection. So kind of having a second viremic response after having initial clearance. Myocardial ischemia, and we do know, viral infections, including COVID-19, lead to a high risk of myocardial ischemia, thrombosis, especially with the hypoxia, and the interruption in anticoagulation, and we know an increased, again, thrombotic risk, secondary pneumonia, COPD exacerbation, given that they had a prior history of COPD. From the COVID, CHF or myocarditis, or worsening of the arrhythmia from medication issues, as well as the acute viral illness. And again, we always have to go through the differential diagnosis and making sure that there's it's just true and unrelated. A lot of people get COVID, and the 2 weeks afterwards they are absolutely able to get other illnesses as well. And so if they've picked up a second viral infection, if they've aspirated, or they have some other incidental illness that is just manifesting around the same time after their COVID-19. So, talking about rebound, this is probably the best study that I've seen in terms of tracking rebound infection. This was done by a group in the United States where they prospectively swabbed and surveyed individuals after their COVID infection, looking at the rate of rebound. So, the rate of a secondary viremia based on testing, as well as secondary symptoms based on symptom screening. And they looked longitudinally for 16 days. Some of them did get nirmatrelvir ritonavir, and there is this, literature around potentially nirmatrelvir ritonavir leading to more rebound infections. This study actually looked at both testing positive again or symptom rebound. Interestingly, the testing positive again by day actually was the same in the Paxlovid group versus the non-Paxlovid group, so people that got observed with no therapy. And, again, we see about a 10% rebound rate in this population, or a 90% probability people clear. Again, no differences between the two groups. There might have been a slight non-statistical Paxlovid reduction, but again, the Paxlovid folks in this prospective trial may have been also a little bit sicker. So, that may be just the counter in terms of immunologic tolerance. And then when they looked at people in terms of their symptomatic rebound based on survey, they did see a marked difference between the Paxlovid group versus the control group. And so this may really be that people may feel those rebound symptoms a bit more in the context of getting nirmatrelvir ritonavir as compared to placebo, but the rate of actual virologic rebound is about the same, and in the 10% range. So when you're counseling folks, there is that probably 1 in 10 risk of having a secondary infection. It may be asymptomatic, but with Paxlovid, it may be more tendency to be symptomatic. So the big question is okay, what do we do, recognizing that, having more virus or viral phase again may predispose to risk? And so this is a large chart review of 92 million people in the United States. They looked at the risk of rebound and compared Paxlovid versus molnupiravir, which is a drug not approved in Canada, and in many studies has an efficacy that's much lower than other therapeutics. In fact, there's some questions of whether or not it even has efficacy. But in terms of, so at the best, consider it a placebo, if anything. In terms of infection rebound, it was higher in the molnupiravir group, or the quote unquote placebo, as compared to Paxlovid here. It's at about 3.5 versus 5%. In terms of symptomatic rebound, again, higher than the placebo, the molnupiravir group had a higher rebound than Paxlovid, 2.3 versus 5.8%. I think the big bottom line here, though, is the hospitalization post-rebound. So of these individuals that had rebound infections, the hospitalization rate was 0.4% in the Paxlovid group and 0.7% in the so-called placebo group. So, I think the bottom line from NIH recommendations here is, outside of very, very certain patient groups, that if patients do experience a rebound infection, then they should just be managed symptomatically. The one group I would say is the major immunocompromised, where you may want to be a little bit more careful with their downstream therapies. But for the average elderly individual that experiences a rebound that's immunocompetent, that the rate of hospitalization is still markedly reduced with getting nirmatrelvir or ritonavir. And that, again, based on most recommendations, that we wouldn't necessarily re-prescribe a course, although there is some clinical trials ongoing to really look at this question a bit further. So next is myocardial ischemia. This is a large retrospective cohort from the TriNetX US Collaborative amongst COVID cohorts of myocardial or thrombotic diseases after COVID-19 diagnosis, and myocardial ischemia particularly. The bottom line here is that there is an increased risk of myocardial ischemia amongst all groups compared to a baseline non-COVID infected group. However, the rate is much higher in those with hospitalization or intensive care stay. As noted, those people probably have more cardiovascular demand based on their acute illness. But there is a small risk that is excess risk that is seen with myocardial ischemia. Now, this may not be specific to COVID. We have influenza data suggesting the same within the first 7 days of influenza, shingles data, pneumococcal data that really do suggest an increased risk of myocardial events after one of those infections. But again, recognize that person 2 weeks post-COVID, that they may be at a slightly higher ischemic risk, and especially if they carry risk factors in, that you may want to incorporate that as part of the differential diagnosis, which I'm sure most people are doing at this point. One of the interesting things is, does vaccination actually affect that myocardial risk? And yes, actually, this large retrospective cohort study that was done in South Korea actually looked at vaccine status and staging myocardial risk. And in this cohort, essentially, the risk amongst fully vaccinated people was markedly lower in terms of myocardial events. It was seen across most age groups. It was seen across diabetes status or non-diabetic status, hypertensive status, non-hypertensive status, or other cardiac risk factors, and obviously as well in severe COVID-19 as well. And so, non-severe COVID-19. So, again, another piece that may be used in your clinical decision-making, that unvaccinated person 2 weeks later who's not hypoxic, but presenting ill to the emergency room, ischemia and thrombosis may be actually much higher on the list. That person that's 2 weeks later that may have another recognized cause that's had a full series of vaccines may actually have a lower myocardial risk or thrombotic risk, and incorporating that into the decision making. Similar data for thromboses. So, there is an increased thrombotic risk. This was a large Swedish cohort, nationwide cohort study that looked at DVT and PE post COVID-19 and saw an increased rate, so about 2.8% higher risk of DVT in mild outpatients with COVID-19. This was a little bit of pre-vaccine data, so take it a little bit with a grain of salt. PE lower, higher risk as well, and again, much higher risk if people were admitted to hospital. Bleeding was actually the reference and was actually baseline for mild groups in that sense. So again, something to think about in terms of DVT and PE. And again, risk factors. This was a cohort in China that was done looking at this, and age, sex, particularly male, obesity, worse socioeconomic status. That actually socioeconomic status is not related, and prior vaccination, so no vaccination was higher risk in that sense. And again, looking at venothromboembolic risk with vaccines, we see there is a marked reduction in thrombotic events, and in this cohort, essentially only 5 events versus 6 events actually in the cohort of 7,600 individuals that had COVID-19. So yes, it can happen. Yes, it can happen in a vaccinated individual. Much more of a risk in someone that's older, male and obese. And again, vaccine status probably still defines this risk of post-COVID thromboembolic events as compared to other risk factors in that sense. Other considerations, so secondary pneumonia, generally rare. I mean, there are a series, they're uncontrolled. There's not many comparators to other viral illnesses. There's 8 to 12% risk of secondary pneumonia. Obviously, observer bias in the context of these people are presenting to care more often. But consider again, and I don't think there's any magic bullet here, if they're sick, if they have dense infiltrates, if they have purulent sputum, if they have high fevers, or if there's some other reason why they could have pneumonia like aspiration. Myocarditis post-infection is rare. We see it often with moderate to severe illness, and does happen occasionally in patients with no severity of illness, and as they're presenting post-acute note. And again, this can happen in people with no underlying cardiac history. And then finally, again, especially if Paxlovid is involved in that patient's care, just make sure you go over drug interactions and what needed to be paused as part of getting on Paxlovid, as that might be the simple answer of why people are sick post-COVID, is that, iatrogenically, we introduced the complication with drug adjustments. And so, always keep that in the background for the Paxlovid patient who's presenting ill after COVID-19. And with that, I'll flip it over to Dr. Saxinger to go over more long COVID management.
Thanks. Next slide, please. So I want to start with a case, and this is a kind of composite real case that I saw a few months ago. A 67-year-old man who self-reports as saying, I have long COVID. And he came into the emergency room with new rash, shortness of breath, and swelling of the legs for weeks. And, before all of this started, he was a very, very active man. And he tested positive on rapid tests 4 months prior to admission or presentation. His COVID illness seemed quite standard. At that point, he'd received 2 vaccine doses. He'd experienced some achiness, stuffiness, cough, low appetite, and felt pretty darn draggy for 5 days. Improved further slowly over the following 2 weeks, but never really got back to normal. He described lingering or increasing fatigue and weight loss and headaches and poor sleep and sweats. His spouse is very interested in alternative treatments for long COVID, and a number of therapies of various sorts have been tried with modest, if any, success. Next slide. And, asking a little further about that, he'd been getting IV therapy at a naturopathy clinic. And it was something called the FLCCC protocol. Looking that up, the FLCCC is a controversial group. The Wikipedia article about it would confirm that it's associated with right-wing groups and vaccine misinformation, and it's a whole bunch of stuff. And it says that it's treating reactivation of dormant viruses and inflammation and clotting and mast cell activation. And the Naturopathy Clinic website long COVID symptom list looks a lot like the Naturopathy Clinic website Lyme disease symptom list, which looks like all the symptom lists, actually, unfortunately. And so people could read this and say, everything and anything I have could be related to my prior COVID infection. And their comment is that breathing difficulties, brain fog, fatigue, and blood pressure abnormalities are frequently seen at our office. So this treatment had been given. He'd been getting IV treatments, but he was honestly not feeling any better at all. Next slide, please. So Paul, I'd actually like you guys to throw stuff in your chat. If you were seeing this guy right now, what would you be thinking in terms of the top differential diagnoses? So I have a proposed list of things people might be thinking. Nobody wants to play. It's okay if you don't want to play. You're all thinking anyway, because we see stuff like this, right? The next slide, please. We'll just move on because we don't have the formal polling going. So, I mean, things that you might consider would be the whole sort of central sensitization pathway type stuff, because he basically came in saying that's what he has. You know, rule out thromboembolism, because some aspects of this presentation sound sicker than they should. Rule out malignancy, because, you know, weight loss and sweats do not sound good. Infectious syndrome, that's new. Given this rash, which I haven't shown you a picture of yet, so this is totally unfair, vasculitis or other immune phenomenon. And then, of course, like he's been getting some weird things. Could this be a side effect of some of those treatments? Yeah, I'm agreeing with the workup people are proposing there. So, you know, just in terms of, next slide, yes, thank you. I trust you. He had kind of a borderline not fever. SATs were pretty cruddy, little tachypnic, looks chronically unwell for a man who was well 4 or 5 months ago. And he has physical exam findings suggestive of congestive heart failure. And he's got a petechial rash, mostly over his legs. His white count's 11.4, creatinine 140, had previously been normal, but it was last done like a year and a half ago, proteinuria and high CRP. I got these images off, not this specific case, but they are representative. Next slide, please. The diagnostic result was received. Blood cultures were done, and 3 of 3 bottles came up within 8 hours with gram-positive cocci and chain, subsequently identified as a Viridans group strep strain strep mitis. It's quite sensitive. He was, you know, had enough cardiac issues that he was waiting valve replacement, but had a cerebral embolic event while waiting for valve replacement, and ultimately had valve replacement and mitral valve repair. Next slide, please. So this actually kind of comes to this issue of what people think long COVID is and what it might as manifesting as in our hospital system. And we have to remember that now pretty much every medical condition that would have occurred in a parallel universe in which COVID never happened, which would be great to live in, everything that happens is happening after COVID infection, vaccination, or both for the vast majority of adults and kids. So long COVID, we don't want to miss it. We don't want to invalidate people's symptoms, and we don't want to miss the other conditions. And in this case, I think this man was seeking care for long COVID when he should have been seen for a progressive medical illness. You know, compatible symptoms at 12 weeks after onset is what all the definitions settle on. But the problem with compatible symptoms is that a ton of studies, even some, you know, national studies from the UK and Canada, will include any single symptom at 12 weeks as being, you know, classed in long COVID. Now, I just gave a talk to several hundred family physicians, and I started off by saying, how are we doing? How are we feeling? Anyone have fatigue? Anyone have any symptoms? Anyone have fatigue plus any other symptoms? And then I asked, if you said yes to any symptoms whatsoever, have you had COVID within the last 3 months? And in that group, 50% of people would have met the criteria for long COVID because they reported fatigue plus or minus other symptoms or any symptom 3 months after COVID. And so, you know, that tells us that a lot of the estimates that are kind of going around are problematic, and that we really probably do need better numbers to understand what's going on. There's one study that I quite liked in terms of longer term outcomes that was reassuring that most people feel better at a year anyway. It was an outpatient younger cohort, I'd have to say, and it was a test negative design. And they looked at quite an array of symptoms that were specific. And, you know, they definitely saw more anosmia, dysgeusia, cognitive changes, shortness of breath, weakness, and palpitations after COVID. But really, the outlook at a year was very good. Next slide, please. And I mean, the too long didn't read version is reassure people that feeling tired beyond 2 weeks, which is the public health definition of recovery, is actually very normal. It doesn't doom you to long COVID, because I think that there's some really scary media reports that freak people out. UK symptom and Australian, actually very comprehensive population-based study, both showed that 80 to 90% of people are essentially fully recovered at 1 month. And by 3 months, it's 93 to 98% recovered. And then the rest of the kind of tail is a bit of a grab bag. And, another study of test positive, test negative, 2-dose vaccinated were 60% less likely to have symptoms than unvaccinated. This was earlier data from the pre-Omicron era, but I think quite reassuring as well. Next slide, please. Examples of media reports, just, one day I looked at what the media is saying about long COVID. Most people who ended up with long COVID had a mild case. Long COVID affecting more than 1/3 of college students. It's keeping people out of work. And this is like the discourse. And so, they asked us as the last move of the scientific advisory group before we stopped doing science and evidence and advice here, was that we had started a long COVID. What's the actual incidence review? Next slide, please. And we found that the data is actually kind of all over the place. The estimated range is usually kind of sitting around 20%, like the CDC and a bunch of other groups say it's 20%. I'm just going to point out that, in Alberta, our seroprevalence for infection is about 78% now in adults. And so that would be 1 in 6 adults would have long COVID estimated. And the definition, therefore, becomes quite important when you're thinking about how do you manage all these people? Like, what do we expect? Next slide. And, if you underestimate, there's a risk that people will use that to say it's no big deal. And I think that's not the case. I think that it's a real problem, and we don't want to invalidate that as a problem, and we don't want to undercut funding that's needed to address the problem. Overestimating, like those media reports, creates a lot of fear, which in itself can actually cause morbidity. And it makes it a lot harder to estimate the healthcare burden. And so when we tried to figure out what we think the current real incidence is, next slide, please. It ranges from 2% to over 50%, and a lot of it is garbage data. In terms of the better studies, there was some studies that looked at outpatients who sought care and their physician diagnosed them as having a post-COVID condition. And that was 1.2 to 6.7% in those studies. In population studies where they had an uninfected comparator group and included some assessment of functional impact, so it wasn't just like, hey, are you tired? Which, most of us will say yes, was 3.1 to 4.1%. And that puts us still with, 100,000 odd people who would have a post-COVID condition in our province. And of course, then there's all the people who actually had an infection, were hospitalized, and therefore are at higher risk of post-COVID conditions. Next slide, please. So those numbers are actually low, but they're not low. Most of the population studies end up coming in at around 3 to 4%. And so there is a vaccine effect. So the ONS data from the UK, 3-dose vaccinated, 4.2 to 5% for Omicron. And when they actually looked for people who had functional limitations from persisting symptoms, it was 3.2% at 12 weeks. And so I think that the fact that they all come in around that right now suggests to me that that's probably where the number is right now. Same thing in the Canadian COVID Antibody and Health Survey. They had 15% prevalence overall, but 3.1% prevalence of limiting symptoms on the early data from that study. Next slide, please. So those scary estimates often come from studies that allow a single symptom like fatigue, and many of them are also from earlier phases of the pandemic, pre-vaccine era, and often they followed cohorts who'd been admitted to ICU or hospital. So, in adults across all variant eras, 19 to 53% will report any symptom at 3 months. And when you look at those that had a comparator group, 30 to 37% of uninfected people report any symptom. So, take it all with a grain of salt. Kids are interesting. Almost no kids had long COVID symptoms in, prospective follow-up studies versus, parent-reported studies, except in adolescents, it looks a lot more like adults. And so the prevalence was 9.7% in male adolescents and 32% in females with single symptom again. So I don't know what to make of that. I think we shouldn't do that anymore, basically. Next slide, please. So I'm kind of winding up here, but vaccination, there is reduced prevalence with vaccination. And healthcare worker studies and population studies would suggest that the reduction is in the realm of 30 to 85% reduction of the risk. And for antiviral therapy, we kind of touched, I think, on this before, but this study, you can't really use it to look at the type of symptoms that we're talking about with long COVID, where there's not a defined alternate medical diagnosis, but there's multisystemic issues that are causing debility. So I don't think that we can say too much about that yet, but I can say, next slide, please, that new studies are coming forward where that's included as part of the design. So we will understand more about that, and I think it's an incredibly important question. And, you know, we have to recognize that the entire population and ourselves have come through an immense trauma during the pandemic, and that affects how people are presenting for medical care. And at the end of the day, the long COVID question, you probably are seeing more patients with kind of cardiopulmonary issues, maybe POTS, autonomic stuff. And that might be coming up alongside other medical issues, but at the moment, there's no specific therapies that are of note. And so you basically assess them as you would assess anyone else with those complaints. And we have to just make sure that we're always using long COVID as a diagnosis of exclusion, which I know you guys probably are, but that patients know that too, because, you know, otherwise they might be sitting around brewing their endocarditis for an extra month before they seek care. Next slide, please. So the dominant long COVID, post-COVID condition symptoms are unlikely to be a sole presentation, I would have to say. I'm interested to hear your thoughts on that. The medical complications that Zane was talking about really require the same diagnostic workup as pre-COVID. And you may see, like, you know, systems review, you might unearth a whole bunch of additional symptoms that could be attributed potentially to PCC. And, you know, unfortunately, I couldn't really get into the referral pathways for long COVID clinics because it varies very much from place to place. But I do believe every province has some long COVID resources where you can start to direct people. I think the primary care crisis is really going to be a challenge for this, honestly. And that, you know, hopefully we'll see that, you know, some extra support for assessing and figuring out long COVID will be maintained. Next slide, please. So, I mean, the good news is that these specialized clinic cohorts might provide longer term guidance, and that actually might end up spinning off in it and helping other similar syndromes that are, you know, an event is followed by a long period of multi-system ill health that is usually difficult to characterize medically. And I think that a work around long COVID might actually end up helping us with all of those other syndromes, which characteristically are hard to handle in the acute care system. Bad news is that, you know, there are people who are wondering if this is going to be a contested disease where people are saying it's not real, there's not a test for it, and, you know, that it's going to become a real challenge within the medical system. And I think that is a real risk. And then the good bad news is that a whole ton of trials on clinicaltrials.gov are recruiting. I think the bad part of it is that some of them are really wacky, like some of them look fine, like rehab, mindfulness, exercise, those look great. Fecal microbiota transplant, lithium, antivirals, cannabinol, nutraceuticals. You know, there's going to be a lot of stuff coming forward, and I think it's going to get kind of busy looking. And some of these trials might be treatments looking for a disease. And really, we have to be very skeptical and rigorous when we look at definitions and the outcomes that these studies use. Next slide. That wraps it up.
Well, thank you very much, Lenora and Zane. That was absolutely fantastic. We're really short on time, but this has been very useful. I'm just going to try and pick the stuff that hasn't been addressed in the chat box. John Rizzo's pointed out the huge difference in recommendations as well as availability of different medications in different provinces. And Lenora pointed out well, even her last slide, there's a lot of subjectivity in the interpretation of incomplete data, for want of a better word. The one question is Paxlovid going to turn out to be the new Tamiflu? Either of you guys got an opinion on that?
I mean, I can start, and it might.
Yeah, go ahead,
Tamiflu ended up being a drug that was stockpiled and then for H1N1, and at the end of the day, it didn't have as much of a beneficial effect as we would hope it would. And it's still a little bit unclear how much it might help in reduction of progression. I think Paxlovid has probably better data than oseltamivir does right now, but I think that the place where it's going to get controversial is for people who lack the risk factors, like they're a younger person without major comorbidities, I think there is some demand for Paxlovid. And I'm not sure that that's something that we should be doing. And if you look at the evidence to hand, it really doesn't support widespread community-based treatment in people without, fairly weighty risk factors. And that's going to be controversial. I'm interested to see what Zane says about this one.
Yeah, no, I totally agree. I mean, I think it definitely does work in high-risk patients and unvaccinated patients or poorly vaccinated patients from their own medical conditions, et cetera. Like it is a life-changing therapy, but the way it's being applied is completely different, and the guidelines opening up more and more is a lot trickier. And so, I think it's just buyer beware. This is a drug that was trialed on risk of hospitalization. As you start using it in a population with a low risk of hospitalization, you're not going to see significant population-based effects, because if your risk of hospitalization is less than 1%, making it much more less than 1% is probably not going to show up on the spreadsheet particularly much, and introduce other risks in that ballpark. And again, I think until we get better studies, long COVID and other things, may or may not, be a secondary consequence of going on Paxlovid in that context. And I don't think we can necessarily bank on that as our use case for younger and healthier populations.
Excellent. And Dr. Bolikov's question about whether you would give a second course of Paxlovid, Lenore, I see you actually said that if they met the requirements, and going through what you said about making sure it's not something else, that you would consider a second course if they tested positive and they had the right indications. Does that sound right?
Yeah, there's one of the things to be aware of is that especially if people are tested by PCR, it's not that uncommon to have a lingering positive PCR even out to 6 weeks. And if people are immunocompromised, like significantly immunocompromised, cancer on treatment, transplant, they can be PCR positive for months. And so if someone has a new symptom complex compatible with COVID, especially if it's more than 3 months out, and they test positive, I would tend to regard that as being a new test positive and assess them according to the risk factors. And if they qualified before, they probably would qualify again. The question might arise, are people at risk of developing resistance if we keep on using it? We don't have an answer for that. And I'm not even sure if all the guidelines explicitly address this, but to me, if it's between 6 weeks to 3 months and there's a recurrent syndrome and PCR test positive, I think you'd probably want to get a bit of additional input, including talking to someone in the lab or getting ID to see if we think this is truly a new infection, or if it might be kind of lingering PCR positivity. So that probably is going to become, an ongoing question, and we probably will get a little bit more data on it, but that's how I would handle it now.
And I think we got one more, just a question again from Dr. Bolikov. Would you suggest that people who've had Paxlovid get their vaccination a bit earlier, considering that it blunts your immune response, the subsequent vaccination?
I actually push back. I think there was some question of rebound being a phenomenon of kind of, you get rid of the virus very quickly, you don't build an appropriate immune response, and the virus rebounds. There is actually some data in rebound, small data, but following rebound patients through their Paxlovid, that they make incredibly adequate T cell and B cell responses. And so I think that hypothesis of rebound is actually not necessarily there. Monoclonals were a bit different because of the fact that the mechanism monoclonal was to leave antibodies in situ, and they may interfere with vaccine responses because of the fact that you have pre-existing antibodies. But I don't think there is any alternative guidance, and I wouldn't recommend alternative guidance for folks who get Paxlovid, as at least the data really does suggest that their immune responses are completely adequate if they kind of recover from their COVID.
Agreed. I would still consider infection a boost. Like in my head, when people talk about what they should do with vaccination, I'm like, well, you're self-boosted now, and so we should look at the next vaccine timing in the context of when's the best time to proceed to get the best immune response. And ordinarily, the answer is 3 months or longer after the last exposure.
Well, thank you both very, very much. Just we do promise people we won't stay long, so I'm actually going to end the questions here. Dr. Shaglin Saxinger, thank you very, very much for a great series. Thank you for all the attendees, and thanking the scientific committee for their invaluable input, the CAPE staff team, all the work putting everything together, include Jeff Allen, who is absolutely brilliant at organizing all of this. Remember, the session's been accredited by the CCFP and the Royal College, so please don't forget to complete your evaluation and claim your credits. You'll get a certificate of attendance mailed out together with the evaluation link. And I encourage all of you to tune in again next Wednesday. CAPE has an extremely interesting lineup of CPD sessions. So keep an eye out and join us as much as you can. Once again, Dr. Saxinger and Dr. Chagla, we really, really appreciate you spending time with us and sharing your knowledge.
Very much.
Thank you.